Good afternoon, everyone. Thank you for joining us for our third day of virtual sessions for our 6th annual North Country Telehealth Conference. Our theme this year is Uniting the Future of Population Health and Virtual Care, which is a theme we came up with pre-COVID. I feel like that future is already here, and I think most of you on the line would agree with that. So again, this is our third day, and today is certainly personally for me the most exciting day because it's our New York State Telehealth Panel Day. This is our, I believe, 4th year doing the New York State Telehealth Panel, and I'll be introducing all of our panelists here shortly. For those who don't know, my name is Katie Cook. I am the Telehealth Project Manager for Adirondack Health Institute. We're located in Glens Falls, New York. All of the sessions this week are brought to you by the North Country Telehealth Partnership, and that is a joint effort between AHI and Fort Drum Regional Health Planning Organization since 2015. So again, if you're here for the New York State Telehealth Panel, you're in the right place. We have folks from the New York State Department of Health, several divisions of the New York State Department of Health, the New York State Office of Mental Health, and the New York State Office of Addiction Services and Supports. We do want to give a sincere thank you to all of our past sponsors. This is the 6th year of the North Country Telehealth Conference, and it would not be possible without the organizations listed on this slide. Hopefully next year we can reconvene in person. And a few housekeeping items. Again, your audio and video have been muted upon entry. To avoid an echo on your end, if you are hearing one, you will want to choose either the computer audio or the phone audio, not both. For optimal viewing, we recommend using side-by-side mode. To activate this, you would click on View Options at the top center of your screen and choose side-by-side mode from the drop-down. You will want to utilize the chat function today to submit any and all questions for our panelists or AHI staff, and we will ensure that your questions get answered. We have left a good amount of time at the end for a Q&A with all of our panelists. And again, this is being recorded, and the presentation and recording will be archived on our website by October 9th. So I want to introduce today's panelists. So here with us today from the New York State Department of Health Office of Primary Care and Health Systems Management is Megan Program. From the Division of Program Development and Management, Office of Health Insurance Programs, we have Kendra Michael. And to answer questions during the Q&A, we have Ronald Bass, who is the Director of the Bureau of Medical, Dental, and Pharmacy Policy, Brett Friedman, the Director of Strategic Initiatives, and Dr. Michelle Griga, Director of Dental Policy. So we do have a dental expert on the line. With us today from the Office of Mental Health Bureau of Inspection and Certification, we have Amy Smith, and Christopher Smith, who is the Deputy Director for the Adult Community Care Group, Division of Adult Services. And finally, from the Office of Addiction Services and Supports, we have Carmelita Cruz, Senior Attorney. I am going to stop sharing my screen, and Megan, you are up first.
Good afternoon, everyone.
Good afternoon.
Thank you, Katie. Let me share my slides here. As Katie said, I am the telehealth lead for the Office of Primary Care and Health Systems Management. And in this role, I provide technical assistance and to our DOH licensed providers and other stakeholders. OPCHSM, that we're the regulatory and surveillance arm of the department. But today I'm going to provide an overview on state telehealth parity law and policy. I really want to emphasize that telehealth at the federal and state level, we really view it as a mechanism or a tool to deliver healthcare. It's not considered a separate service or specialty. It's just a way to deliver healthcare. And really, on the federal level, at the state level, our state laws on telehealth really revolve around reimbursement. So telehealth parity law was passed in 2014, enacted in 2015, and has been, on the Medicaid side, really expanded every year since. And it affects public health law, social service law, and insurance law. So what this does, it requires commercial insurers in the Medicaid program to reimburse for a service delivered via telehealth if that service would have been covered if delivered in person. So if a service was covered by a payer in person, a payer can exclude reimbursement for the service if delivered via telehealth. So on the commercial insurer side, we have what's known as reimbursement parity. It doesn't necessarily state payment parity. So the level of payment for a service via telehealth may be reimbursed at a lesser rate than in person. There's been, several bills that have been drafted to achieve this in New York State, but currently what we have is considered reimbursement parity. On the Medicaid side, so that's what public health law refers to, Article 29G provides more specific requirements for reimbursement, and in standard Medicaid, that we do have payment parity. So Medicaid will pay the same amount for a service delivered via telehealth than for telemedicine if that service is at the same rate if delivered in person. So it's important to know our legal definitions for telehealth and the different modalities, because reimbursement really will fall in line closely to how things are defined. So for insurance law, again, this is what applies to the commercial payers. Telehealth is defined as the use of electronic information and communication technologies by a provider to deliver a service to an insured individual located at a site that's different from where the provider is located. Now, it's important to note that in insurance law, that's where the specifics kind of begin and end. It's a very broad definition. It doesn't specify any particular modalities. It doesn't define originating site where the patient has to be located, or distant site where the provider has to be located, or the provider type. So there is a lot of latitude in law on the commercial side. Public health law, you can see the definition of telehealth is very similar. It includes more specific services like assessment, diagnosis, consults, etc. But it's important to note, as I'll explain in a little more detail, and my colleagues from OHIP will present on, that there's further definitions in public health law that that specify what can be reimbursed in Medicaid. So it's really important for the commercial side to always consult with individual insurers regarding their contracts and policies on modalities, on where the patient can be located, and provider type. I'm going to talk a lot about what's currently on the books, and then try to drill down what's been expanded since the COVID-19 public health emergency. So on the commercial insurance side, there's been emergency regulations that were passed by the Department of Financial Services. So these went into effect March 16th, and they're effective for the duration of the state of emergency. I've got the link there to the regulatory language. The slides will be available so everyone can access all the links in the presentation. But really, for the length of the state of emergency, it prohibits insurers from imposing cost sharing, co-pays, and annual deductibles on telehealth services that are in network for that insurance plan. And telehealth has been expanded for these emergency regs to include audio only and video modalities as appropriate for covered network services. And DFS has a really good FAQ webpage, and the link is there. So now I'm going to move on and provide a very high-level overview of public health law as it relates to Medicaid reimbursement, and my colleagues from OHIP can get into more detail on the more specific billing requirements. So I won't go spend too much time. But here's, per public health law, here are the telehealth providers that are defined for Medicaid reimbursement. So we've got really, this list has been expanded ever since the original passage of Article 29G. You can see here the list, and we go on. It includes PTs and OTs, certified diabetes and asthma educators, our DOH licensed healthcare providers, hospitals, DNTCs, nursing homes, home care, hospices. And then this slide encompasses the more recent additions to public health law, distant telehealth providers. So they include credentialed alcoholism and substance abuse counselors, KSACs, early intervention program and service coordinators, our Article 16 OPWDD clinics, and their certified, non-certified residential and day programs. And then the most recent addition and expansion for eligible telehealth provider are care managers that provide care management services under these specific programs of patients that are medical homes, health homes, OPWDD, hospice, and OCFS voluntary foster care agencies. Before the public health emergency, all practitioners on the list in the previous slides, and really in general, any private pay practitioners, if a patient is located in New York State, then that provider providing the service via telehealth needs to be licensed by state ed. And for Medicaid reimbursement, they would need to be an enrolled Medicaid provider. During the public health emergency, via executive order, the licensure and registration requirements have expanded a bit so that most healthcare providers wouldn't necessarily need to have a current registration if they have a New York State license. And then out-of-state providers, if they're in good standing in the state that they're located in, could provide a service to someone located in New York and provide them a service via telehealth for the duration of the state of emergency. But it's always, we must always be mindful that practitioners must act within their scope of practice. And then if the patient is located at an Article 28 facility and they're receiving a service from a distant site provider, that Article 28 at the originating site where the patient is located must credential and privilege the telehealth provider at the distant site. And there is a specific part of public health law that states that the originating site can rely on the credentialing and privileging of the distant site hospital, assuming there's a written agreement between the two Article 28 facilities. So according to public health law, this is our list of originating sites that are eligible for New York State Medicaid reimbursement. And I want to again note that this is the law currently on the books, and I'll get to what is happening during the state of emergency. But you can see here eligible sites where patients can be located include our Article 28, so that's hospitals, nursing homes, diagnostic and treatment centers. We've got hospice, they can be located at a hospice program. They can be located at any of the mental health law authorized clinics, Article 31s and 32s, Article 16s, OPWDD programs. Of course, patients can be at a private physician or dental office in New York, adult care facilities, all public, private, charter, elementary and secondary schools, school-age childcare programs and daycare centers in New York State, and then also a patient's place of residence in New York or their other temporary location in or outside of New York State within the 50 United States or US territories. So this, again, want to reiterate, this is on the books, this is pre-COVID. Patients can be located in their own home to receive, a Medicaid member can be in their home and be eligible for the provider to have reimbursement for a service. So as I mentioned, under insurance law, we have a broad definition of telehealth that doesn't further define a specific modality. But on the public health law side, for the Medicaid program, the standard Medicaid fee-for-service program, we do have specific modalities listed in law. And they include telemedicine, store and forward, remote patient monitoring. And then what's highlighted here is new statutory language that was recently passed. And so this definition, these modalities have been expanded to include audio-only telephone communication, but to the extent defined via regulation. And I'll get back to what that means in an upcoming slide. And also some new language is that previously telehealth was excluded fax only or electronic messaging only transmission. So if there was only a email or a message via a patient portal from a patient to a doctor, and there was only that kind of back and forth via a messaging, that wouldn't qualify for Medicaid reimbursement. So however, there's more recent language that says fax only, electronic message only transmissions are not precluded, but they need to be part of an additional modality such as telemedicine, store and forward, and RPM. So just quickly, here is our legal definition of telemedicine. This is what most people think of when we say telehealth. It's a live audio, video, visual conference. It's a back and forth exchange between a distant site telehealth provider, and for Medicaid, again, they need to be on that list via defined in public health law, and the patient is at an originating site. So it's a two-way back and forth audio-visual encounter. Store and forward is our next modality defined in public health law. This is asynchronous. It's the transmission of patient health information, such as an image or a video, taken by a provider where the patient is located and transmitted to a telehealth provider at a different distant site, a different location. So a patient can't necessarily upload their own image to a provider. Really, the definition is the provider where the patient is taking patient health information digitally and transmitting it to a provider at a different location for their assessment and evaluation. That provider concludes their assessment and evaluation and submits the report back to the referring provider from the originating site. And then remote patient monitoring is a combination of synchronous and or asynchronous electronic information, which collects personal health information at an originating site, and then it's transmitted to a provider at a distant site, usually to treat more ongoing chronic conditions that really require very frequent monitoring, such as blood pressure. So I mentioned that we've now got legislative language that includes audio-only telephone communications. But really, Medicaid would potentially in the future reimburse for this additional modalities, including audio-only, as they are defined in regulation. And that reimbursement is contingent upon federal financial participation. So at the federal level, state would need to work with CMS for approval for the funding to be able to reimburse for audio only. Now so everything I've mentioned up until this point exists, pre-COVID. So patients being able to receive telehealth services via their home, that's already on the books. So all of that, will continue once the state of emergency is over. But obviously, the landscape has changed so much given the public health emergency. So just briefly to summarize the massive expansions in state response to the pandemic, Medicaid has really expanded to provide the ability of all Medicaid providers in just about every situation to use a variety of communication methods as appropriate to reach their Medicaid members. And this goes back to effective March 1 for the duration of the state of emergency, and it includes reimbursement for telephonic assessment. And Medicaid was able to develop 6 different payment pathways, and those are all detailed in a May 2020 special edition Medicaid update. So really all providers and to all members, very rapid expansion. There's a great FAQ document listed here, and there was a webinar that was conducted. So if folks want more information on all of that. And just to note that during the state of emergency, originating sites where the Medicaid member is, that can be located, it includes a member's home during the state of emergency. But again, public health law says that Medicaid member can also be located in their residence in general, but it's during the state of emergency, there's really no limits. It can be outside of their home as well. And then distance sites, the telehealth providers can be anywhere in the 50 US states or other US territories. And it does some more expansions to include FQHCs and then patient providers in their home and in their homes, and then also expands things for the dually eligible population. I'm going to turn our attention now and talk about some high-level differences between our state agencies today. We've always gotten a lot of feedback that it's very hard to navigate the regulatory differences between DOH, OMH, OASAS, OPWD, etc. And we've all committed to work together and develop a guidance document between our agencies. This was very close to final right before the pandemic hit. So if our issuing of guidance is on hold until we see what happens after all of these expansions with the state of emergency, but it's something that we're all still very committed to. The various agencies have worked hard to align policies together in the best interest of all of our populations. I also want to note some overall guidance that, I've said previously that under insurance law, we've got very broad definitions for telehealth that would allow for different modalities and different originating and distance type situations. So you really must be mindful of the requirements of individual insurers, different policies, different contracts, etc. And then also that, pre-COVID and after the pandemic, any provider really needs to be licensed, certified, and registered to practice in New York State if the patient that they're providing a service via telehealth to are located in New York State. And that provider may also have to be licensed in whatever state they're physically located in, depending on the requirements of that state. And as I've mentioned, telehealth, we really consider it to be a mode of delivery and not a separate, specialty or regulated service, standalone service. It really is just a way to deliver care. So you really have to also be mindful of the other laws, rules, regs, your standards and competencies around whatever service, that underlying service that's being provided, and be mindful of the state scope of practice issues, privacy and confidentiality, patient consent and record keeping. So, before the pandemic, the platforms that were used to transmit the communications between patient and provider or provider to provider, they would need to have had a, a business service agreement. But for the nationwide state of emergency, on the federal side, the Office of Civil Rights has waived their enforcement of fining providers that might not have these BAAs or use encrypted connections, if, assuming that providers are doing their due diligence to keep patient confidentiality. So that's just for the state of emergency. We expect that once the state of emergency is over, that will be, the HIPAA compliant software platforms and transmission would go into effect again. So now I'm going to spend some time to talk about very high-level differences between our state agencies. As I've mentioned, in public health law, we've got, for public health law for Medicaid reimbursement, there are 3 different modalities that are defined: telemedicine, store and forward, and remote patient monitoring. So for DOH, Article 28 providers that are seeking reimbursement through Medicaid, those are the 3 modalities that are acceptable. And including, the more recent audio-only language that's yet to be developed via regulation, so that would apply then too. But for Article 31, OMH licensed providers, and Article 32, OASAS licensed providers, the only modality that's recognized is a live audiovisual conference between patient and provider. So that's synchronous encounter. For OMH, it's called telemental health, but the definition of it is very similar to telemedicine. And for OASAS, it's termed telepractice. And again, the regulatory definition is the same as telemedicine. So no store and forward, no remote patient monitoring for Article 31s and 32s. On the regulatory side, for our Article 28 facilities and other DOH specific and licensed and certified programs, there are not specific regulations exclusive for telehealth. As I mentioned before, you really need to think about other specific regulatory issues regarding that service, or if there's a DOH, program or designation that requires, certain levels of staffing, those still need to be followed, but there's no specific regulations for telehealth for our DOH Article 28s. For Article 31, OMH, and Article 32, OASAS, there are regulations specific for those agencies. And those regulations have to do with whether or not approval is needed, the type of distant site provider, and where a patient can be located. So for Article 28 and other DOH licensed providers, approval to use telehealth is not needed. For Article 31s and 32s, they are required. You do need approval. My colleagues at OMH and OASAS will talk about the changes that have happened due to the pandemic and the types of approval process, how that might, how that's been changed. But pre-COVID, in general, there's a process that's needed for OMH and OASAS. I do want to take a higher step up. If private providers that are not working for Article 28, 31s, or 32s, these don't apply to you. If you're not seeking Medicaid reimbursement as well, this is not, you don't have to adhere to these different categories that I'm outlining. On the distant site provider, if you're seeking so this goes back to whether or not you're seeking Medicaid reimbursement. If in Article 28, seeking Medicaid reimbursement, the provider types are outlined in public health law, Article 29G. Those are the slides that I presented earlier. For OMH clinics and other programs, the Article 31s, The distance site providers are outlined in OMH regulations, and they are included here on the slide. And similarly for OASAS, by their regulations, there's certain provider types that can be authorized to provide services via telehealth, telemental health, telepractice. And then patient location, and my colleagues, again, they'll talk about their most recent updates to their regulations, and then also during the pandemic. And for patient location, the differences between the agencies, this is where the agencies have really worked hard to align with each other. So again, this is for Medicaid reimbursement for Article 28. It include the originating site can include a Medicaid member's home or other temporary location, and that's similar for OMH clinics. And then for OASAS, it's an OASAS approved location, and that can also include the patient's home. So I'm going to wrap it up there. We've got some contact information. My best contact is here, telehealth at health.ny.gov. And then I've listed out some OHIP contacts as well. So now I will pass it along to my fellow panelists.
Thank you very much, Megan. Kendra, you are up. You can share your screen and your video. Awesome.
Share my screen. There we go. Can you hear me, Katie?
Yes, I can, and I can see your slides. Thank you.
Great, thank you. Hi, I'm Kendra Michael, and I'm here today from the New York State Department of Health with Ron Bass. I'm from Medicaid Policy. And today we're going to give you an overview of telehealth and telemedicine. Some of the information may touch on some information that Megan already went over, so I'll try to move through that as we go forward. So an overview of telehealth terminology, as Megan explained, telehealth is a broad term. It's used to refer to a variety of arrangements in which the healthcare provider interacts with the patient remotely. For Medicaid, telehealth is defined as the use of electronic information and communication technologies to deliver healthcare to patients at a distance. And then we also do have the modalities outlined here, and Megan did go into those as well. So telemedicine being synchronous for consultation with an originating site provider and a distant site provider, and store and forward, which is the transmission of the electronic data, and remote patient monitoring for things such as blood pressure and blood glucose levels. Sorry, my little arrow is I apologize for that. We went a little too far forward. So telehealth is consistently demonstrated to be both clinically effective and a cost-efficient means of delivering healthcare services and improving population health. Evidence on the efficacy of telehealth has shown particular promise in several important areas, including but not limited to patients with healthcare access issues, especially those in rural areas, care management for patients with chronic conditions such as diabetes and hypertension, and patients with behavioral health diagnoses, including substance use disorder and psychotherapy needs. Despite the promise of telehealth and improving care and reducing costs, utilization has been relatively low in Medicaid. You can see here, this is a chart that explains the state fiscal year 2018-2019 out of a total number of 56,134,793 encounters, only 20,489 or 0.036% were delivered via telehealth prior to the pandemic. But during the COVID pandemic, telehealth utilization has skyrocketed. An example here is New York City Health and Hospitals have reported Prior to the pandemic, they were billing less than 500 telehealth visits monthly. And in March of 2020, that increased to nearly 55,400 billable telehealth visits during that month. And then again in April of 2020, that increased by almost another 30,000 to 83,000 billable telehealth visits. And reimbursement in New York State Medicaid. So New York Medicaid has been on the forefront of telehealth coverage in its Medicaid program, and it's been far more progressive with coverage than Medicare. From 2006 to 2015, major Medicaid coverage expansions included specialty consultations and hospital outpatient departments and additional classes of allowable providers, including teledentistry. In 2016, enacted public health law and amended social services law expanded Medicaid telehealth coverage further, but we were still subject to the federal reimbursement limitations. In 2018 and 2019, the expansion of telepractice coverage for substance use disorder services and reimbursement for additional physicians and other fee schedule providers such as optometrists and certified diabetes and asthma educators. And they also permitted the home, there was an expansion to permit the home to serve as an originating site. For fee-for-service during this time frame, reimbursement generally followed face-to-face encounters, and Medicaid managed care requires parity for coverage of telehealth, but permits negotiation of rates between plans and providers. And now we're going to go over some of the telehealth flexibilities during the public health emergency. In response to the COVID-19 pandemic, Governor Cuomo issued several executive orders to suspend or modify laws necessary to aid in coping with this emergency. And here's a link to the executive order. And I think Megan also mentioned in her presentation that the current emergency has been extended to October of this year. So emergency Medicaid telehealth guidance was issued by DOH, effective for dates of service on or after March 1st of this year, and includes the following telehealth flexibilities. Coverage was expanded to include telephonic coverage and associated reimbursement to further expand eligible practitioners to all qualified practitioners currently serving Medicaid patients and out-of-state providers. It further expanded eligible distant and originating sites to include not only the patient's home, but practitioner homes, and extended federal privacy waivers to New York encounters and allowed for additional use of additional technology, including Skype and FaceTime. So these flexibilities impact both how telehealth may be furnished and what services may be reimbursed. Telephonic services are reimbursable where face-to-face visits may not be recommended, and it's appropriate for the member to receive these services by telephone. Audiovisual services are always preferred. So telephonic services should really only be used when audiovisual services are not possible. The emergency telehealth guidance allows providers to bill Medicaid for services that can be appropriately delivered remotely during the COVID-19 state of emergency. Payment pathways are established for Medicaid providers, including those contracted with managed care plans to bill for telephonic encounters. Rules are relaxed on distant and originating sites, the types of clinicians, facilities, and services eligible for billing under telehealth rules. And again, it allows for use of non-public facing technology like Skype and FaceTime with appropriate patient authorization. That's very important. And this includes expanded technologies that may not fully comply with HIPAA requirements. The Medicaid managed care plans must follow fee-for-service telehealth billing policy included in the March 2020 Medicaid Update Special Edition regarding telehealth and telephonic services during the COVID-19 state of emergency and subsequent updates. Those are live documents and they are updated frequently, and the links can be found in the appendix. but the plans may follow separate reimbursement as highlighted on the next slide. The managed care plans must also cover telehealth and telephonic delivery of all benefit package services that are appropriate to be delivered by this modality and a means to properly care for the patient. The plans may not limit member access to telehealth and telephonic services solely to their telehealth vendors. They must cover appropriate telehealth and telephonic services provided by other network providers as well. The managed care plans may have separate detailed billing guidance from Medicaid fee-for-service. They must establish payment pathways for telephonic encounters, which may mirror the 6 payment pathways outlined in the Medicaid update that Megan touched on also. And they may use, but are not required to use, the telehealth encounter codes or payment pathways that are used by Medicaid fee-for-service. And in the absence of negotiated rates for telehealth and telephonic services, the plans must reimburse network providers at the same rate that they would be reimbursed for a face-to-face encounter. And here's a telephonic reimbursement overview. The payment pathway chart is in Appendix A of this slide presentation, but it basically has 2 payment pathway sections. Lanes 1 through 2 are for use by fee schedule billers, and those are primarily office-based practitioners. And lanes 3 through 6 are for all other billers that primarily bill for clinics and other services. And then on this slide, slide 15, further breaks down those payment pathways. During the public health emergency, the monthly time requirement for remote patient monitoring has been reduced to a minimum of 10 minutes. And during the emergency, reimbursement for store and forward services has increased from 75 to 100%. Article 28s and FQHCs, the clinic provider or practitioner may be in any location, and this includes their home during the public health emergency, and the patient can also be in any location, including their home. How will things evolve once the pandemic ends? This is the big question, the question that we keep hearing. The governor partnered with SMIT Futures and a diverse group of 16 individuals to explore answers to this question. The emergency has fast-tracked telehealth, and what was already a robust telehealth program grew exponentially. Now that the department can catch its breath, our focus really needs to be on what works and what doesn't. Look ahead and reimagine. The Reimagine New York Commission will focus on connectivity, access to telehealth, and workforce development. In addition to recommendations from the Commission, DOH will focus on interagency coordination, MRT2 proposals, feedback, and surveys. We know there are definite advantages to telehealth, and we don't expect any abrupt changes. That said, there's a lot happening on a federal level, and it's important your voices are heard in Washington. Now's the time for DOH to collaborate with other state agencies to measure outcomes and explore best practices. Most of all, it's time to listen to our providers and our members to ensure the best care for New York State Medicaid members going forward. Appendix A has, again, an outline of the telephonic charts that are further broken down and include the appropriate codes to bill for or to bill with. And Appendix B has some additional resources and guidance and some links to some great information. Again, I'm Kendra Michael, and here's our BML. Should you think of, there'll be time for Q&A at the end of everyone's presentation, but should you think of anything after today, please feel free to reach out and we'll be happy to get back to you with an answer. Thank you and have a good day. I'll move on to the next presenter.
Excellent. Thank you, Kendra. You can stop sharing your screen. I'm going to pull up the OMH. Oh, where is it? Okay. Okay, Amy and Chris, you're up.
Okay, this is Amy. Can you hear me well, Katie?
Yes.
Okay, great. So we're gonna go through very quickly. I'll talk first, and then Chris will follow up. But we just wanted to go through really the current flexibilities that we've put in place that have been afforded during the executive order. We'll talk very briefly about the streamlined process, and then I'm going to talk a little bit about some proposed regulation changes to Part 596. So in terms of the current flexibilities that have been afforded during the pandemic, we have a rapid approval process, so providers could submit a self-attestation and then they could immediately begin using telemental health. We expanded the definition of telemental health practitioner, so it would include any professional, paraprofessional, or unlicensed behavioral health staff. We did remove the limitations and restrictions around location of the practitioner while providing services, although we did maintain that the practitioner must still be licensed in New York State, as was mentioned earlier. We expanded the definition of telemental health to include telephonic in addition to the two-way synchronous video. We suspended the requirement for an in-person evaluation prior to delivering services via telemental health. And then we also had a relaxation of any program-specific limitations within the regs or guidance. So some examples would be with ACT or PROS or inpatient units. And more recently, in July, we worked on streamlining our process to apply for the permanent approval. So this would be for anybody that wants to be covered to deliver services after the executive order ends. So this would be a permanent approval of telemental health. So our licensed providers can now submit one administrative action, or AA, per agency instead of doing it site-specific. It must be clearly identified, though, which program sites are included. So you want to include satellites, named sites. If you have different program types, list those if you want them to be included. The providers need to complete Appendix 1, which is in our guidance document, which is the attestation, and also include a policy and procedure document when submitting the AA. We do ask that if the agency is licensed for more than one program type, that you clearly identify how telemental health will be used within those different program types or settings in that policy and procedure. And Appendix 2, which used to be required, is no longer required. It really can just be completed by the agency to help guide them and assist in purchasing equipment or choosing a platform. The field office may conduct a remote readiness review. It's either or both the originating or distant sites, but really in most cases we think that that will not be occurring. But certainly talk with your field office about whether that's something that will need to happen. And if we make any future regulatory changes, providers are not required to submit a new application or AA. They could just update their policies and procedures and inform the field office of any changes that you're going to implement going forward. And then lastly, just to touch very briefly on some proposed Part 596 regulation changes. We're hoping to expand use of telemental health services for the Article 9 and involuntary admissions. We're also looking to expand the definition of telemental health to include that audio-only piece as an acceptable option when it is determined appropriate by the clinician and in accordance with regulation and also in agreement with the client. We want to expand the definition of a telemental health practitioner to also include additional staff approved by the office. So we want to keep some of those flexibilities in place about who can deliver the service. We're also looking to remove the requirement around the mental health practitioners. The way the reg is currently written, those mental health practitioners need to be located in New York State, and we would like to expand that so that they could sit elsewhere in the US similar to the prescriber. We're removing or hoping to remove the PROS and ACT-specific language within the regulation. The program-specific language will now reside in guidance. And we're also hoping to remove the requirement of that in-person initial assessment prior to the delivery of services via telemental health. So now I'll turn it over to Chris so he can go through his portion.
Thanks, everybody. So I just wanted to talk a little bit about what OMH is thinking about sort of the next steps from a programmatic perspective, in addition to all of the regulatory changes. And really thinking about the interaction between telehealth, telemental health services, and in-person care moving forward. I mean, we're very happy about the developments with telehealth, and we think it's really provided a lot of access. There have been a lot of positives associated with it. A lot of providers have found that telemental health has reduced no-show rates, addressed what are a lot of really major transportation barriers, especially in rural areas, but also in, throughout the state. And for some individuals, find it easier to engage via telemental health, especially through telephonic care. But there are also some drawbacks. Privacy can be an issue, and clinically, especially again through telephonic only, which has really been a significant part of the work that has taken place in the mental health system. There can be a reduced ability to assess nonverbal information and to really do the same kind of thorough assessment someone can do in person. So really where we're going to be coming down in the long run and want to start thinking through how to shift care to some extent, even still during COVID, is really thinking through more of a hybrid model. And I just wanted to walk through a few data points that we've gotten from both our own surveys and provider surveys. So we conducted a survey of about 6,000 recipients and families of recipients throughout New York State. And by and large, the findings were very positive about the implementation of telemental health. So 85% of people were comfortable or very comfortable with using telemental health. But we want to, it's 85% still leaves 15% who were uncomfortable or very uncomfortable with telehealth services. Similarly, a provider in Western New York surveyed about 3,700 of their recipients. And for them, they found a pretty even division between people who preferred a mix of in-person and telephonic care, people who liked solely telephonic care, people who wanted on-site care, and people who wanted video or a combination of video and on-site care. So that was a pretty even division in that sample. And then a large New York City provider surveyed about 1,500 of their participants in treatment, housing, and outreach programs. So kind of consistent with the OMH findings above that I mentioned already, they found about 10 or 15% of individuals were less connected, felt like they were getting less support, which again, the flip side of that is that 85% or so to 90% were doing well, but still there's a small subset that we need to be cautious about. And another interesting finding that they had was that while 80% of individuals were interested in continuing to receive services remotely, 83% said that they would prefer a mix of remote and in-person care. So we think that all kind of comes together, and also with conversations we've had with other providers about where we want to go with this system as a whole. So I mean, really, and we've been making this pretty clear throughout all of the guidance that we've issued so far, even during the pandemic. Our expectation is that decisions really need to be made about the mix or the proportion or how in-person and telemental health play out. Need to be made on a person-centered basis as part of the person-centered treatment planning process, and take into consideration the individual's preferences, but also the risk status, and both risk their psychiatric or mental health risk status, but also risk of COVID contagion and social distancing, et cetera. So we're planning on moving forward with developing guidance and some sort of general principles about how we think these determinations should be made. And then we'll also be making more specific program guidance decisions about how this can play out, especially in working with high-risk individuals and high-intensity programs like ACT, Inpatient, and CPAP. And then there's also concerns about how to really, on a long-term basis, for some of our group-oriented modalities like PROS, partial hospitalization, day treatment, to be able to provide on an ongoing basis those kinds of group-oriented services, and also where there's a real intensity of service that's required. So we are a bit concerned about how those will play out over time if they're done primarily virtually. And we've also heard from a lot of recipients of those types of programs that they miss the social interaction and the social support that they obtain through the in-person interactions. And last, I mean, while the data that I've described so far is really survey-based and a lot of more kind of anecdotal data, we're working on trying to really use the harder data that we have access to, claims data and other data sources, to try and make better decisions about how to proceed going forward. So that's really sort of where we're at right now. I don't think, I don't want this to be mistaken to say that we're gonna be telling you can't do telehealth going forward, or that, you know, we're not gonna be doing any wholesale changes in the guidance, especially during the disaster emergency. But we do want to start thinking through, you know, making more nuanced, person-centered, and clinically oriented determinations about how to balance the different kind of care that's provided to our recipients. So, thank you.
Excellent. Thank you very much, Amy and Chris. All right, Carmelita, you are up for OASAS. Just looking for perfect. So if you could come on video.
All right, great. So you can hear me, right?
Yes.
Okay, great. So I'm Carmelita Cruz. I'm an attorney with the Office of Addiction Services and Supports. And in following along kind of with what Amy and Chris just talked about, I'll talk about some of the OASAS COVID-related flexibilities, and then talk about a couple of the regulatory changes that you'll be seeing from OASAS as well. So probably one of the bigger flexibilities that's very often talked about in our system is that peers have been delivering services. We've also allowed for unlicensed staff similar to OMH to deliver services via telepractice, but peers have been delivering peer support services, and we've been hearing really great feedback from our providers. So this has been going very well. We're actually working with the Department of Health to figure out, you know, how we can maintain peer service delivery post-COVID. So we'll have more on that eventually. In addition, you know, our providers are delivering audio-only services. Megan talked about that earlier, so I won't focus on that too much. We've waived the in-person requirement. Previously, the OASAS regulation required that a patient be seen and determined suitable for service delivery via telepractice. We've waived that, and that's actually something that we're looking at changing in the regulation. And there are some medication-assisted treatment flexibilities that have also been very successfully implemented during the COVID pandemic, both for buprenorphine and in our opioid treatment programs with methadone. So, and this is really largely a result of federal flexibilities that have been allowable during the pandemic. So buprenorphine induction has been allowable both by telehealth and by audio only. So I think, as we're able to look at data over the next couple of months, I think that one of the things that we will definitely see is that this is resulting this is pretty widely used in our system and by independent practitioners that aren't certified addiction treatment programs in New York State, to initiate buprenorphine without having to do meet the in-person requirement. And this flexibility is, again, a federal flexibility. It's in place as long as the feds allow us to continue this. There is a chance that this is something that might be maintained post-COVID. We've been talking with individuals at SAMHSA and at the DEA, and I think that they're looking at the ability to maintain buprenorphine initiation, at least by telehealth, perhaps not audio only post-COVID, but there's more information on that will hopefully be coming out as well. In addition, OASAS and SAMHSA worked together pretty early in the pandemic. At the very beginning of March, when the governor first declared a state of emergency, to try and figure out how the pandemic would impact the opioid treatment system. Our OTP providers know that the vast majority of patients are going in on almost a daily basis to receive medication administration. So there were a couple of different flexibilities that were put into place, including some delivery of medication in limited situations, and then also really expanding the use of take-home medication for patients that don't meet the take-home time and treatment requirements in the federal regulations. So we released guidance a couple of months ago on additional rate codes that have been added, which allow for weekly pickups of medication with a follow-up by telepractice or by telephone. And that's also a great flexibility in our system that I think, to the extent possible in a post-COVID environment, we will look at maintaining to some degree, but that again is subject to federal approval because opioid treatment programs are very heavily regulated by the federal government. So those are pretty much the COVID flexibilities that have really been utilized in the OASAS system. And now I'll talk about a couple of regulation changes that will be coming fairly soon. So we propose some changes to our Part 830 regulation, which is the designation regulation for OASAS. It covers acupuncture, telepractice, and program endorsements, which are new in our system. So we were already making some changes consistent with some program endorsements that were in the 2020 State of the State. So we decided while we were doing that, we would make a couple of changes to the telepractice language, and I will review those with you briefly. The public comment period actually just ended on this regulation. I think it ended last week. We're looking at the public comments that we received right now, and we anticipate submitting this regulation for adoption probably sometime in October. So you'll see these changes go into effect in the next couple of months. We will also be issuing an updated standards document consistent with the changes in the regulation. So providers should be aware and make sure that, in addition to looking at the regulatory language, you're also looking at the standards document that accompanies the regulation. So just kind of reviewing a couple of the changes to the telepractice section in the regulation, we provided some clarifying language, based on a lot of questions that we get or waivers that we receive. Providers often submit waivers to waive regulatory provisions on certain things, such as, a practitioner working from their home pre-COVID, obviously, a practitioner working from their place of residence, which was already allowable. So we're just kind of making some changes to make sure everyone understands what things are already allowable under the public health law and the OASAS regulation. So it changes to the distant site and originating sites to make sure that practitioners and patients can be in their place of residence or other identified space consistent with the public health law. We are making a change to the definition of telepractice, essentially, of the telecommunication system that's required to state that it can be audio and or video as approved by the office. So this change is being made consistent with the statutory changes that Megan talked about earlier, which may allow for audio-only services pending federal approval and federal financial participation. So this is our way of just, making the regulatory change now that we're doing it. So once this goes into effect, we don't have to go back and worry about changing the regulation in the future. The standards document will maintain that audio-only services are only allowable during the COVID pandemic. We're also removing all of the references to services. So providers may remember that we previously had categories like psychosocial interventions. I think last year we added the ability for individual and group counseling to be delivered via telepractice. We're actually taking out those service categories. So providers that are designated to deliver services via telepractice may deliver any services that are medically necessary and obviously that are reasonable and can be delivered via telepractice. Medication administration isn't something that isn't a service that can be delivered via telepractice because it requires face-to-face interaction with the patient and actually, administering medication. We're removing the requirement that providers submit a plan with their attestation. We required previously the attestation, the plan, a review of policies and procedures. We're actually eliminating the requirement that providers submit a plan. So now it'll just be the attestation and policies and procedures that we will be reviewing. And just as a reminder, I know Amy talked about the new process for OMH. The OASAS process is that a single attestation may be submitted for per provider and including all of the different programs that provider operates. So if a single provider entity operates an outpatient program and a residential program, and they want designations added to operating certificates for both of those programs, they may submit a single application with the policies and procedures for those programs and include both of those PRUs, any applicable PRUs. We are removing the requirement for the initial in-person visit prior to delivery of services via telepractice. So that's coming out of the regulations. And I did actually receive a couple of questions around some regulatory language on revoking designations. That was taken out of the telepractice section. It was actually just moved into its own section at Part 830.7. So those regulatory language around revocation of designations is still applicable. So providers won't need to submit a new attestation or application in order to continue to provide services. You'll just need to update your policies and procedures consistent with the regulation, and OASAS will be sending out a notice to all providers once the regulation and standards document are adopted and posted on the website to make sure that everyone is aware. In terms of providers being designated to provide telepractice services. OASAS put an emergency telepractice designation process in place where providers for the COVID pandemic, where providers essentially just submitted a single form to certification. Their email response was essentially their approval from the agency. And we've really been encouraging providers to submit their policies and procedures and their attestation for review and permanent approval from the agency prior to the executive orders expiring. So most of our providers and OMH providers are aware the executive orders have been extended on a monthly basis, and we get lots of questions on this every month about what's happening. I think the current date is October 4th or 5th. Providers are encouraged to submit their permanent applications before then so that they can get their permanent approval. Hopefully the executive order will be extended again, but we obviously won't know that until much closer to the date. And OASAS has been sending out provider notifications once those executive orders have been extended. I think that we probably, we've reviewed so many applications in the past couple of months. I think at this point we've probably got the vast majority of programs in the OASAS system approved. We get only probably a handful, 5 or 10 applications this week and last week. So I think that we've done a pretty good job in terms of approving everyone so far to date. And then I know Chris talked about the provider survey that went out through OMH. OASAS is actually looking at conducting a similar survey. We're working on finalizing that now. There will be one survey that goes out to all of the providers, and then there is a different survey that will be going out through the New York Certification Board to all of the certified peers in New York State. With some questions about their service delivery utilizing telepractice and telephone only services during the COVID pandemic. So I think that those are pretty much all of my updates.
Okay, if the panelists could hop back on, I'm going to work through some of these questions. Again, for everyone on the line, if you could please submit your questions in the chat, and we have plenty of time to get through them. We have about 45 minutes, which I think will be more than enough. So I'm just going to kind of go in order. I'm going to start with you, Megan. I'm realizing the sun is directly on my face, which I'm not being a good telemedicine steward if I don't have good lighting, but my blinds fell, so that's where we're at. So Megan, a question came in for you from Felicia Parker. Just looking for a little bit more of clarification or reviewing the slide that you presented regarding the addition of case managers as telehealth providers. She wasn't able to catch all of that slide and was curious how you define case managers.
Oh, this is a great, it's a great question. Let me see if I can share my screen again and get back to the presentation. We'll go to that slide.
Sure, and for everyone on the line as an attendee, this is certainly the opportunity to ask the right people the questions that you typically send to me and then I just send to them. So if you want to hear it straight from the source, please submit your questions into the chat box. I think this was the slide.
Yeah, okay, so this is the most recent update to public health law, which it now includes care managers as a distance site telehealth provider. So they're employed or under contract to provide health home program services. They could be a patient-centered medical home, be employed by PCMH practice. It could be an OPWDD care coordinator. They could be employed by a hospice or a voluntary foster care agency certified by OCFS.
Okay, thank you for re-reviewing that.
Absolutely.
Another question, and this may be a little bit broader of a question, I'm not sure if you guys can answer it, but curious if you know if Medicare and commercial insurers cover out-of-state providers licensed in New York State, or is this on an insurer by insurer basis pre and post COVID? Now, Megan, I know you spoke to the department's stance on that, or New York State Ed's stance on that, but I don't know if you can speak to Medicare or commercial necessarily. They would probably follow New York State Ed if it's New York State, right?
Yes, so any practitioner that's providing a service to someone geographically located in New York needs to be licensed to practice in New York State, but then under executive order for the state of emergency, some of those licensing and registration requirements have been expanded. So, for telehealth and also in-person COVID-19 response, and the majority of healthcare practitioners, if they're in good standing with a license out of state, they can provide care to someone located in New York State. If they have a New York State license but aren't currently registered, they can still provide care to that individual located in New York State. Now, for Medicare, they have a different set of eligible telehealth providers. So their provider list looks different than what we have for Medicaid reimbursement. But similarly for Medicare, they have to have the state license under pre-pandemic, but then under executive order, they could follow what is happening that I just outlined in terms of licensing and registration. So Medicare, it's a different provider list. They can be located out of New York for patients that are in New York State. And then on the commercial side, that is an insurer by insurer check that you need to have for each of the plans.
Okay.
It's not a one size fits all.
Right. All right, you can stop sharing your screen. Thank you. We do have a teledentistry question, and we do have a teledentistry expert. Howard Reese mentioned that there were dental experts on this panel. Can they briefly discuss what they are seeing with regards to teledentistry? So I know Dr. Griegitz is on the line. So, hi.
Hi, I'm here, Katie. Can everyone hear me?
Yes.
Okay, could you just repeat that question again? What we are seeing in terms of teledentistry?
Yeah, can they briefly discuss what they are seeing with regard to teledentistry? I know that's kind of a broad question, but maybe the direction that the department is taking with policy or reimbursement, I imagine that's what he's getting at.
Okay, well, we did see, we did cover teledental visits prior to COVID-19, but we have seen an increase in claims for teledentistry since the COVID-19 happened. I think it was, toward the middle of March or so, most dental offices closed except for emergency or urgent care. So that was really the only means of, kind of triaging patients to see if they needed emergencies treated and then determine if they did need to come into the office. So we did see an increase in claims for teledentistry at that time. It hadn't really been widely used prior, although we had in January, sent out some guidance about billing for teledentistry. So we had everything in place, but I think, having the pandemic happen, it kind of was something that was available that providers could use in that particular time. So we have seen an increase in claims. We hope to see that it's being widely used as time goes on. I mean, it's certainly, we've discussed a lot of different ways that it can be helpful, especially for access to care. It may be difficult now even to get into a dental office. They're pretty they're pretty booked up. They're not able to see as many patients as quickly now because of all the safety precautions that have to be provided. So that's another means of maybe triaging folks to determine whether they really do need to present to the office or whether it's something that can be handled, over a telehealth visit. So we're really hoping to see that there is an uptake in teledentistry over time. I would feel like it could be really beneficial in a number of ways.
All right, thank you very much. Next question for Megan again. Will parity law continue to pay the same rates, I'm assuming for telehealth, as for services rendered in person? I'm assuming her question means like post-pandemic, so I don't know if you can elaborate on that, because I know right now it is one-to-one, right?
Well, current insurance law, we have coverage parity, meaning that an insurer has to reimburse a provider for a service that's within their network of covered services. We don't have the payment parity in legislation. So that would be something that would need to be permanently changed. And there has been some action and bills drafted in past sessions regarding this to achieve payment parity. I do hear that during the pandemic it's one-to-one, but I believe that new legislation would need to pass to allow for payment parity.
Correct. Okay, this next one's for OASAS. During the executive order, in-person buprenorphine injections were waived. Any sense if this federal waiver will continue post-executive order?
So we aren't sure. We're certainly hopeful that it may. There had been some discussion for the past couple of years, actually. We've been waiting on additional regulations and or guidance that really clarifies prescribing controlled substances via electronic means and use of telepractice. So these conversations were already happening. Obviously the pandemic kind of changed things. I think that part of what we're looking at is the effectiveness of utilizing buprenorphine to initiate, but we're hopeful. This is an area I think where providers are always encouraged to do some federal advocacy on their own, especially for those providers that are actually using this with their patients to really talk about how things have been going.
Okay. This next question I'm going to pose to all of you. And it's more just what your perception is, but what were the barriers to telemedicine before COVID? There were some data points that were mentioned of pre and during and kind of somewhat post COVID. Why was there not more volume previously? That's like the $1 million question. Anybody want to take that one on?
I don't mind starting. Our Office of Rural Health has conducted a few studies in the past with not just rural providers, but statewide. And their most recent survey of providers around telehealth found that it was some of the reimbursement and perceived regulatory barriers that folks maybe just didn't know how to bill or if they were allowed to or not. We absolutely know, I think, across agencies that that providers have been utilizing telehealth, but maybe not using the modifiers to bill. And we know that certain providers have been fortunate to receive grant funding, so they didn't have to necessarily bill for specific services. So I think it's a combination of not knowing what to do or how to bill or how to coordinate within their system to use the proper modifiers so that it would be reflected in our data, and then as we've talked about, Medicare, Medicaid, and all the private insurers, they might have different requirements, and so that can be a barrier to folks too. So I think it's a combination of those, and I'll let anyone else jump in on what they think.
I can jump into Megan. This is Brett Friedman from DOH as well. I think to build on some of what Megan said, there was both provider cultural issues and training issues that would, how to use the technology, do you have access to technology, how do you deliver care effectively through the different telehealth modalities. And then there was also on the patient side, a viewpoint that there was a strong patient preference for going in person, building on the traditional means of encounter. And then I would say the third factor that I think has been identified through surveys and anecdotal reporting has been the lack of availability to commercial telehealth applications to utilize telehealth effectively, where Telephonic's been a big source of expansion through the pandemic. But do people have access to broadband, which is a major barrier in rural areas? Do they have access to high-speed wireless with the ability to remove data caps or data limits from utilizing telehealth? And do patients have a private place to access telehealth away from family members or roommates that may not want to be involved in a telehealth encounter, especially one arising from a resident? So I think those cultural and training challenges have been identified as one major hurdle. And I think one area where, at least within DOH and OHIP, we feel like, the pandemic has been a really, beneficial experience for getting people comfortable with the process more than, say, a reimbursement parity issue in and of itself.
Good point. Anybody else want to respond?
Yeah. From an OMH perspective, I think a lot of what Brett just mentioned about the cultural issues were very important in a delay in the mental health system. Also, our regulations, we took a very conservative approach with really sort of stepwise increases in access and allowing telehealth. And our most recent expansion was really just a few months before COVID. And so I don't think a lot of providers have really had the opportunity to take advantage of it. And I think we're also just in a system that's constantly moving and constantly changing, and just identifying the resources and finding the time and the energy and the money to make all of these changes within the provider systems I think were a real barrier. But when people had to do it, they had to do it. And I think that's one of the real highlights of an upside to this horrible experience that we're all going through is that it really enabled this change in our system, which hopefully will have positive outcomes for years to come.
Mm-hmm. Yeah, I would agree. I think very often we heard before that whether it was real or just perceived, but that the equipment could be very cost prohibitive. And I think in the beginning it was, but prices have come down. And as Chris mentioned, once everybody had to do it, and they realized that, okay, maybe this isn't as expensive as we thought it might be, and it is working.
Agreed with what everyone else said, and just in terms of regulatory barriers, the OASAS regulation went into effect I think in January of 2018. We also went a little conservative at first. I think this is the third round of edits that we're making to kind of ease up some of the regulatory restrictions. So I think as the agency and our provider system got used to providing services this way, which was very new to our providers, we have learned a lot in the process and have tried to reduce and remove barriers that providers identify as much as we can.
Excellent. Thank you all for that. A quick positive note, just wanted to say thank you to OASAS for the quick and detailed communication, along with adapting the regulations to make it possible for us to continue to provide services throughout the pandemic. So I always want to share a tidbit of positive.
I always like positive feedback, so thank you.
This question, I think, is for the DOH team. Are there exclusions with commercial insurance companies covering telemedicine visits with no cost share? Are commercial insurances allowed to still charge cost share on non-COVID visits? Not sure if that's anything you guys would be able to answer, but.
Yeah, that's going to be a DFS question, not a DOH question.
That's what I thought. All right. This one's a comment, and actually I kind of had a question on this. So the Reimagining New York Commission, that was actually really exciting to see. Somebody made a comment that it should also focus on patient awareness and communication. And I'd also be curious, with that commission, is it only state individuals that are involved in it, or is there an opportunity for external organizations to provide input?
So I can jump in there. I've been one of the DOH liaisons to that commission. It is, I'll try to take the questions in turn, at least working backwards. As part of the commission's fact-finding process, they've met with individuals from across the country, both in other states, to learn about their telehealth delivery mechanisms. They've met with people like, nationwide leaders, people like Joe Kvedar, who is the head of I think the Telehealth Provider Association nationally. And they've, really looked at ways that the state has approached telehealth and what the barriers are, whether they're cultural, whether they're reimbursement, whether they're patient focused, to go to the other question. And their goal is to make both a series of short-term recommendations, quick wins, if you will, to try and pursue and build on the momentum through COVID to make telehealth more of a permanent aspect of our telehealth delivery system, and then to advance a series of legislative reforms, likely as part of the upcoming year's budget, to to help sustain some of the statutory impediments to Folsom telehealth delivery. So I would say in both questions, there has been a core focus on cultural issues on the patient side as well, in addition to some of the technical barriers to patient access, like broadband and wireless data. And then there has been, I would say, national fact-finding with regard to, all aspects of the telehealth program. But obviously with a focus on any, on any specific individual state insights.
Okay, thank you for expanding on that a little bit. Another one for DOH. Where does health home care coordination fall relative to the administrative action, since it's more DOH focused? So that may actually be an OMH question too. I'm not sure.
Yeah, this is Amy. I think because it's governed by DOH, it doesn't fall under us to give approval for that, is my understanding. And I went back to look. I think there was some guidance issued back in March around health homes, and so yeah, I don't think that comes from OMH.
Anybody else want to take a stab at that one? All right.
Yeah, Katie, can you repeat? Can you repeat the question, please? This is Ron.
Where does health home care coordination fall relative to the administrative action, since it is more DOH?
Right. So I guess I'm not real clear on the question. Maybe we can ask the question.
The person who asked it wants to maybe provide some more context.
I mean, it's probably about how do you get approved to provide telehealth? Because the administrative action is the OMH process to get approved.
Right.
So I would guess that that's what they're asking, is how does one get approved to be a telehealth provider if you're a health home?
She just responded, yes, that's what she.
I think that approval has to come through DOH, is my understanding.
Okay. All right. Next question. This one I'm not sure if you guys will be able to answer. If the insurance carrier is not a commercial New York State plan, but is a plan from a different state, are they required to pick up the cost share and or deductibles as well?
Yeah, that's going to be a DFS question under the scope of their circular. But I would say as a general matter, DFS doesn't have authority to regulate insurers that aren't licensed in New York State. So if there's no hook for jurisdictional licensure, then, you know, the insurer would probably argue that the circular does not apply to them.
Okay, I'll have to get DFS on the panel next year.
A lot of commercial insurance questions, that's right.
Yeah.
And Katie, it's Kendra. If you want to forward the health home question, we'd be happy to bring that back.
Okay, yes, I will do that. Next question, is there discussion taking place to enable federally qualified health centers to be reimbursed for remote patient monitoring? Is there any appetite for creating a chronic care management like reimbursable program under Medicaid?
Yeah, this is Ron. This is a question that came up early on in the COVID pandemic when the public health emergency was first declared, and we are looking at QHCs and remote patient monitoring. We are waiting for the Reimagine Commission to issue their recommendations, and we'll look at FQHCs and how to incorporate the different modalities of telehealth into the FQHC payment structure once we get those recommendations. I think it'll be a total package of looking at the recommendations coming out from the commission, as well as what other changes we can make in the future to accommodate all the telehealth modalities for all the providers.
Excellent, thank you. This question's for OASAS. Will the allowable reduction in minimum billing requirements stop once the state of emergency ends on October 4th?
Yes. At this point, I think the answer is yes. We haven't discussed how we would go about being able to maintain those post-COVID. So I think that we'd have to look at that.
Okay. This next one's also for OASAS. It's a bit of a longer question, but this individual manages a pain management clinic with an employed pain management physician who wants to expand into MAT. Barriers are access to, I think, MAT providers and good partnership with an MAT program. Is it possible currently, and what are your feelings about the future of MAT, that this could be integrated into our pain management program using telepractice? Could patients be present in our clinic and we provide access to telepractice providers to engage patients in MAT remotely? He understands that this question may be too complicated for this forum, but I figured I'd ask.
So it is a little bit of a complicated question. I will say that at least for buprenorphine, any physicians, physician's assistants, nurse practitioners that get the Data 2000 waiver to prescribe buprenorphine can do so. They don't have to be employed in an OASAS certified treatment program. They have the independent authority to do that within their scope of practice. So if those practitioners exist within your practice, that's something that's already permissible. If you're looking at partnering with the treatment program in some capacity, if you want to, shoot me a separate email, I'm happy to kind of talk through where in the state you are and connect you with our regional office and maybe some OASAS certified programs in that area.
Excellent. That was the last question that came up. So I am going to call an audible and say we can wrap up 20 minutes early. So I want to give a sincere thank you to everybody who attended, and especially to all of you on video right now, as well as the other folks from DOH who so graciously came on and took time out of your busy days. I know you have a lot going on with working on the pandemic and policy and getting the information out. So again, thank you so much for doing this year after year. And again, this is being recorded and it will be on our conference website the week of October 5th, no later than October 9th, as well as the DOH slide decks will be shared. If anybody has any follow-up questions, things that they think of after the fact, please reach out to me directly. kcook@ahihealth.org, and I will be able to connect you to the appropriate party. Please join us tomorrow morning at 10 a.m. We have our 4th telehealth conference day, and we'll be kicking off with a presentation from UVM Health Network. Until then, thank you to all of our state folks, and have a wonderful evening. Bye-bye.
Bye, Katie. Thanks.
Thank you.
Bye.
Thank you. Have a good day.
You too.